That's everyone in from the waiting room.
Okay. Well, it's 1 p.m. Welcome to today's Grand Round. I have two very interesting presentations, and I'd like to invite Quilliam Webb from Hepatology and Transplantation to start with the first one. Please, Quilliam.
Thanks very much. Thanks for inviting me to come and speak. So for those I haven't met, relatively recently appointed consultant here, about 15 months now, and going to speak about crowdsourcing COVID-19 in liver transplantation. And obviously this grand round and everyone's lives recently have been pretty coloured by COVID. But what I want to do is, and the project I'm about to describe, relates to the early part of at least the UK's COVID epidemic. So in this graph, which I updated over the weekend, the sort of first peak between the first sort of around March or so, 2020. And I note today, although it will seem like much longer, it was only a year ago today that the first vaccine was given in the UK. And what I'm going to do is I'm going to start with a case. I'm afraid we've got me doing a case because none of the juniors in hepatology wanted to do it. And then that leads into a small research project, which is the source of the title. So without further ado, the case is of a man who's 42 at this point, who was referred over to Cambridge from one of our referring hospitals for the liver transplant programme. And he had a past history of ulcerative colitis, diagnosed around the age of 30, so about 12 years at the point of referral. Primary sclerosing cholangitis, identified around the age of 40. So this is this typically inflammatory bowel disease associated issue with the bile ducts, with a representative, not the patient's cholangiogram on one side of the panel, with this alternating, stricturing, fibrosing pattern with beading of the bile ducts, progressive obstruction, infections, and secondary to the sclerosing cholangitis cirrhosis. He had cerebral AVM, and he had developed cirrhosis, jaundice, and fluid overload, and was quite ill when he was referred. So bilirubin of over 200, deranged clotting representing deranged synthetic function, low albumin, and so forth. And he's listed for liver transplantation back in 2017. He undergoes liver transplantation later that year, complicated by bleeding. When there's been a lot of bleeding, often the surgical team don't make the biliary anastomosis immediately. The abdomen is packed and then go back perhaps 2 days later, which is what happened here. And then a few days later, there's concern over flow across his arterial anastomosis. And 5 days after his initial transplant, he has an aortic conduit formed. So with a representative diagram here, this basically being an alternative route of bringing arterial blood to the new liver with some donor iliac artery typically used to make a new anastomosis to the aorta here infrarenal below the renal arteries, and then bringing blood up a longer route than the typical direct hepatic artery to hepatic artery anastomosis. The problem with that, of course, is that it's somewhat more prone to thrombosis. And indeed, this is exactly what happened for this patient. So this is now about a year later. He develops some abdominal discomfort, ends up having a CT, and hepatic artery thrombosis is diagnosed. What you can see in the picture on the right of the screen is a liver abscess starting to develop in the center of the liver. And what you can't see, because it's just a single slice, but you can't see the bright contrast that's highlighting the aorta there, running in through the hepatic arteries because there is no flow. And in result of this, he's developing recurrent infections. His liver function becomes deranged again, and he's listed for retransplantation. And he's on immunosuppression, of course, at this point, although it's minimized given the recurrent infections. And then we get to the nub of this. He's transplanted later that year, age 46. So this is 4 years after his first graft, but this is a fit and well man, other than his liver disease. So he's independent, he's working, and comes in for his transplant. Everyone's swabbed, this being around October. so prior any immunisations in the UK, but with COVID lockdown ongoing. His COVID swab negative on admission, but he had recently been in a crowded wedding. He's extubated successfully. However, he becomes more hypoxic, becomes coronavirus positive, and develops progressive respiratory decline and sepsis, perhaps partly contributed to by a subcapsular hepatic hematoma. But ultimately, he has progressive lung disease, is managed prone. You can see in the X-ray representative here, he has a tracheostomy after a period. He's considered for ECMO, but ultimately declined given his complex medical past, and ultimately succumbs to COVID-19 pneumonitis that presumably was required in the immediately preoperative period. And this sort of difficulty with coronavirus and its interrelation to liver transplantation is, sets up a difficult school of thought, in the sense that we're taking patients with poor liver function but no medical immunosuppression, exposing them to some risk in relation to transplantation, then exposing them in risk in relation to acquiring COVID by bringing them to hospital, and then converting them from having mostly into having good liver function but medical immunosuppression. And the point of all of this, early in the pandemic, we had no idea whether having poor liver function had a particularly significant effect on one's outcome from COVID, nor whether having medical immunosuppression, such as is used for a liver transplant, has a particular effect on one's outcome for COVID. And just to illustrate what was happening, this chart on the side is the red, the number of offers of livers across the UK, in the blue, the number of liver transplants performed, and in the sort of grey colour, the number of cases, which matches the graph I showed earlier. And so there was also a real squeeze on transplants. So what was the right thing to do with our patients? Should we have been pushing ahead with transplantation? And what was the relative risk? And then just to emphasize, what I'm about to show you was sort of a very rapid, in terms of research timescales, 100 days or just over 100 days between the two dashed red lines here at the beginning of the pandemic. So, and actually before this chap, the case I've just showed you, who was in October 2020, before he came to this hospital. And this was what the title refers to. We launched a crowd-sourced, i.e. the data coming from the crowd, approach to attempting to rapidly characterize factors associated with poor outcome from infection with SARS-CoV-2 in these two groups of patients: patients with chronic liver disease, so advanced chronic liver disease, the kinds of people we'd likely to be transplanting, and also patients with prior liver transplantation. And I've just got this quote at the bottom here, a Cambridge quote, in the sense of we were starting somewhat hypothesis free and looking for a lot of data points, but really looking to find out what was associated with people dying from this infection, as so many people were in hospital at this time. So the project became this, this being an online submission, which is open, so advertised online and no specific registration required, of a data capture form run through a platform called RedCap, which is run by one of the universities in the States, but is also, there's an instance run here, and many listening may have used it, and then promoted through meetings, so society meetings, Twitter, and word of mouth. And what we did with this form is we looked at those data submissions that were incomplete, and then looked for extra information from the submitter by email, and then excluded those that were not complete. So this had the extra step of meaning that we were going back to people submitting from a sort of verified centre. We only included PCR positive cases because at the beginning of the pandemic there was, due to shortage of testing, quite a lot of difficulty with case ascertainment, in the sense of a lot of clinical diagnoses made on imaging or otherwise, but they are excluded. And really our point of interest here was analysing cases at the end of whether they died or been discharged, as in the end of their disease course. And as you'll see in a moment, to provide some comparison, for our liver patients. I was in Oxford at the time, and so simultaneously we captured the same data set on every patient who presented to the well, the 4 hospitals actually, not just the John Radcliffe Hospital, but the 4 Oxford University hospitals who were SARS-CoV-2 positive, and derived the same data. And then I'll present some descriptive statistics, some logistic regression in relation to death, so factors associated with death after SARS-CoV-2 infection, which was the thing we were most interested in. And also, although this was not directly head-to-head, to get some idea of head-to-head comparison between both the chronic liver disease groups and the liver transplant groups with people without liver disease, so the sort of Oxford group, basically, propensity score matched analysis with the same points of outcome. And what we did is we ran the registry for 1,000 submissions and had those from a number of countries, as you can see highlighted on this map. And then what I'm going to present is summary data really from these 2 papers. So the one on the left in this dark coloured header, chronic liver disease, and the one on the right in what's described as brick red on what I used to make the slides, one from transplant patients, so 2 papers there. And in terms of, it's a busy slide, but just going through it, the 2 groups, we ended up with 745 patients with chronic liver disease after exclusions, chronic liver disease without transplantation, and then 151 patients who'd had a liver transplant. And in this leftmost panel with the sort of blue-grey colours, what we have is the 4 bars from left to right denoting chronic liver disease without cirrhosis. And this is multiple etiologies. Child-Pugh A, so this is cirrhosis that's compensated. Child-Pugh B, so cirrhosis with potentially some features of decompensation, and Child-Pugh C, decompensated cirrhosis, but essentially worsening cirrhosis from A being least bad to C. And you'll see that within the cohort, the rates of those requiring hospitalization were equal amongst those groups. However, in essentially all of the other outputs here, we have a very steep gradation in relation to severity of liver disease. So submitting physicians' opinion of whether the person required ICU, whether they're actually admitted to ICU, the difference here being that a proportion were declined ICU largely on futility grounds, requirement for renal replacement therapy, and also most strikingly perhaps death. So huge increase in death in those with chronic liver disease, especially advanced chronic liver disease. And by contrast, perhaps, and this is unadjusted but comparison, again, no particular difference in the rates of hospitalization between the transplant patients and our control population, nor of a requirement for intensive care. Big differences in the rates of being admitted to ICU care. So a large proportion of our comparison cohort through comorbidity were thought inappropriate to be admitted to ICU, but actually fewer deaths unadjusted amongst the liver transplant cohort as compared to the general non-liver disease cohort. So some contrast there. And this is from our graphic abstract, but to make 2 points. One, in this middle circle, that a significant proportion of the patients with cirrhosis decompensated, i.e. developed new ascites, jaundice, bleeding or encephalopathy with their disease. And 2, that they weren't all dying, those who did die from liver disease, 3/4 of them were cardiorespiratory, this being the 3rd circle on the right, the rightmost circle. So they were dying from cardiorespiratory causes, so essentially from COVID. And they were dying at every stage. This just showing how from top to bottom advancing liver disease and sequence through the hospital. So from being hospitalized, from once admitted to ICU and once receiving invasive ventilation. So really awful prognosis for anyone with Child-Pugh C cirrhosis and COVID, i.e. most of those who we would be considering for transplantation. Age fed into this very significantly, and these 2, we came to calling them tree plots. I don't know if they have a proper name, but are showing age bands sort of across the y-axis, and then along the x, the further out from the middle each bar is going is the rate of mortality, so the case fatality rate in that age band. And what you can see in the chronic liver disease cohort on the left, that there was a strong association with age, with greatest mortality towards the top. But in this advanced cirrhosis cohort, we've got a big chunk of young people dying with COVID. And as I said just now, predominantly from COVID pneumonitis, but that the same pattern is not apparent amongst the liver transplant patients with gradation with age on both sides. And then here, just the summary table to try and keep things brief of risk factors associated with death in the total chronic liver disease cohort. And I've dimmed the variables that were not significant after multivariable analysis, and you'll see a very strong association with age, but a huge, as suggested by the earlier graphs, association with Child-Pugh class, i.e. how severe the liver disease was, and then also an independent association when adjusting for etiology with alcohol as an etiology. So alcohol cirrhosis doing especially poorly here with COVID. And the same chart, but with different variables from the liver transplant cohort, the same finding of a strong association with age. We had a number of patients who had a non-liver malignancy submitted to the registry in whom there was a strong association with mortality, and we took that to be a marker of extreme frailty and lack of appropriateness for prolonged support, and also with renal function. And at the bottom of this chart is a selection of different immunosuppressant regimes, none of which was significantly associated with death in the transplant patients. And here, what I was mentioning at the start is the propensity score matched analysis. So we matched, I haven't included the details here, but on various combinations of the factors listed at the bottom. And this was to try and allow some comparison of the chronic liver disease cohort on the left with those without liver disease. And you'll see again this gradation in mortality. So a huge difference with the Child-Pugh C up to plus 40% in absolute terms versus mortality rate in those without. And in the transplant side, 4 different models of different combinations of adjustments to match the comparison cohort with our transplant cohort, none of them showing a significant difference in outcome for the transplant patients. So what this was then was a very rapid way of concentrating information from a large number of different sources in what was relatively uncommon at the time. So coronavirus in patients with chronic liver disease and their outcomes, and pooling this and trying to get it out as quickly as possible. So in chronic liver disease, advancing disease is associated with very poor outcomes from COVID-19. Amongst the liver transplant patients, age and comorbidity dominated, but actually having a liver transplant did not appear to be strongly associated with adverse outcome. And I think we and others felt that that was good reason to be continuing to transplant people, despite the logistic difficulties of doing so. I think it offers one demonstration of a way to get such information at speed during a pandemic. There are quite a few caveats to this, and I suspect people will be thinking them as I go along. So first of all, the landscape's changed. All of these are pre-immunizations, pre any of the therapeutics really being approved, even dexamethasone. We've missed out the difficult problem of perioperative infection, except for the case at the start, which can be very severe. So all the transplant patients included were established. The denominators, both in terms of the population and the cases that people are submitting, are unstable. And then, of course, is the potential for selection bias. It's somewhat different cohorts compared to the propensity score matched analysis. And it's also very difficult to account for variations in approach to care in international setting. But so having said that, I just want to say thank you to the others who worked on this with me. So some of the guys from Oxford down the left. We also worked with a team in University of North Carolina who contributed to coordinating things from their end. And we were kindly supported by a number of sort of liver organisations listed on the right who got the word out and encouraged people to submit. Thanks very much.
Thank you so much. This was terrific. I mean, it's very important information actually, and acquiring that insight so quickly in the midst of the first wave is impressive. Before I would like to encourage everybody actually putting questions in the chat. And before I go to Will's first question, actually, may I ask you, with regard to your results on the liver transplant cohort, did you see any differences in between or trends in between different immunosuppressive regimes? And do you think essentially that the relative protection that the transplant cohort had is primarily an effect of immunosuppression itself?
Yeah, I think this is really interesting. So within our cohort, we didn't see any association with particular immunosuppressant regimens. Others have reported a variety of different immunosuppression regimens being preferable. So I've seen reports that mycophenolate, for example, are both positive and negative, calcineurin inhibitors, positive and negative. And separately, though, we've done some pooled analysis of a number of different projects, and there doesn't seem to be a dominant risk associated with any particular immunosuppressant regimen, at least within and amongst liver transplant patients. And I don't know, in relation to the second part of your question, one could imagine, given that a significant proportion of the therapeutics that have since become in widespread use are immunosuppressant, dexamethasone, tocilizumab, etc. One can imagine that perhaps some of these people have a blunted systemic inflammatory response. I'm not sure, and what's difficult with this is getting enough numbers to really unpick the comorbidities which are common in the liver transplant patients to really know. Yeah.
Okay. Thank you. So, Bill Jelson, were you able to look at time from transplantation and whether that was associated with mortality?
So we did look at whether people were less than a year after transplantation, and we didn't see at least a particular effect, but we had very few people who'd been transplanted very close to their coronavirus infection. And that's, I think, one of the big caveats here, because both that they're weaker, but they're also typically more immunosuppressed, so that might be different. And also there's quite a good evidence or big evidence base in relation to poor outcomes from major abdominal surgery for those who are infected in the sort of perioperative period, as I think probably manifested by the case I started with.
Mm-hmm. May I ask for other questions? Actually, perhaps I may ask you another one. This is related to your cirrhotic population. What has since then been published on the relative risk in that cohort with regard to immunosuppression, in particular with IL-6 receptor blockade?
In cirrhosis?
Yeah.
I haven't seen anything specific on coronavirus outcomes in IL-6 blockade in cirrhosis. I mean, something we have noticed through this registry, which continues to recruit actually, is that there's a significant reluctance to use a number of the new therapeutics in people with advanced liver disease through anxiety about destabilizing liver disease. So especially things like remdesivir, which I appreciate is different, but also tocilizumab and steroids. There are a number of people reporting that they didn't give them. So, but I don't know specifically cirrhosis and tocilizumab, for example.
Okay. And how do the outcome parameters that you observed in your liver transplant patients actually compare with other transplanted organs, such as renal?
So I'm less expert on this, but looking at the UK data for renal patients, the renal patients seem to do a bit worse than the liver transplant patients on average. But I think that a significant proportion of that was because a significant proportion of those patients had impaired renal function themselves, which is a major risk factor. So if one corrected for that, some of that difference went away. But the liver transplant patients seem to do relatively relatively well, and equally lung transplant patients I've seen pretty poor outcomes, but they're pretty uncommon.
Another question actually from Will. When do you think we should immunize patients against COVID following transplantation? Good question.
So short answer is we don't know, and we're discussing this in the department, but my inclination is early on. So as in a few weeks afterwards, we essentially know that the duration of the protective response in relation to coronavirus immunization is impaired in our patients, which would fit well with hepatitis and flu immunization as well. And we've actually had a mini wave of people being 6 months after their second dose and having infections amongst the transplant patients recently. So my feeling would be that we should get on and immunize people, really knowing that we're going to be ending up immunizing them again and again and again. And I suspect that that's going to be something that's, a feature of our lives to come.
And any idea actually why alcoholic liver disease has done so particularly badly?
Yeah, that's interesting. I think the thing we're struggling with, and we've got more data than this and are analyzing it at the moment, is one of the things that affects the alcohol liver disease patients is that they are particularly susceptible to being sort of not taken to ICU, as in thought inappropriate for being taken to ICU. So unpicking how much that effect is variation in care for the alcohol patients and how much it's something underlying about their physiology is uncertain, but it seems to be something that's been reproduced by others elsewhere, that alcohol patients do worse than at least biochemically similar liver disease for another reason.
Okay. And interesting question actually from Stephen Bennett, who is coming up actually in the next presentation. Have you noticed any difference in the incidence of COVID-19 since the UK program of shielding ended for CEV patients?
Amongst the transplant, CLD, I don't know if I can answer that really. I mean, I know that a lot of our patients have continued their own shielding, but what it's come to in a population terms, I don't know. The slightly reverse comment I'd make is that there's some evidence out there that for people with CLD, the people who are presenting to hospital are particularly advanced. So the state in which people are coming to the A&E or whatever, they're putting it off until the absolute last moment, and the much more jaundiced, much more decompensated, etc. So there's evidence to do with that, but I'm not quite so sure about rates in relation to shielding.
Perfect. Thank you again. This was really interesting, and we are coming to our second presentation in today's Grand Round. Outbreak of heart failure at Most Tavern by Paul Cacciatolo, and on behalf of Stephen Pettit, please.
Thank you very much. I'll just share my screen, and hopefully you should be able to see my slide. So thank you very much for the opportunity to share with you this case from my time as a registrar in the Advanced Heart Failure Department at Papworth Hospital. It's an opportunity really to share.
Oh, sorry for interrupting you, actually. I think you're in presenter mode. Do you want to switch screens?
Of course, bear with me a second. I'll get that changed for you. There we go. Will that work?
Go to the next slide, actually. It hasn't swapped yet.
Let's try it again.
It's still in presenter mode.
Will that work?
Yes, this is perfect.
There we go. Okay, we're up and running. Apologies for that. Okay. Yes, so really I'd like to highlight a very complex diagnostic conundrum in this case, and to highlight the interplay between different heart failure services. I'm presenting here with Dr. Stephen Pettit, who's a consultant transplant cardiologist, and Steve tells me that he's got a prize for anyone who can connect the obligatory cryptic title with the case in hand. So I'll move swiftly along. So this is a gentleman who was initially 42 years of age when he presented in 2017. He presented to his local hospital with symptoms of heart failure, fatigue and breathlessness. And in the A&E department, he was also felt to have clinical signs of tamponade. They undertook an echocardiogram, and indeed there was a pericardial effusion, which was felt to be hemodynamically significant. But also an underlying moderate left ventricular systolic impairment. It was unclear what the etiology of that was. It was global, not regional. But given that he was clinically in tamponade, the decision was taken to drain his effusion. This was done successfully to dryness. Samples were sent, as you'd imagine, for cytology, which showed epithelial cells, but not much else, and microbiology, which returned a negative result. His symptoms improved with drainage of his effusion, and he was discharged home with what was felt to be an assumed myopericarditis, but the etiology of which was uncertain. He was asked to come back to cardiology outpatients, but never quite made it. We'll review his comorbidities. He's essentially a fit gentleman, a non-smoker, doesn't drink much alcohol. Previously worked in the United States as a paralegal analyst, and a very active person, undertook martial arts to quite a proficient level. Because of this, he was felt, due to his high impact sport, he developed what was felt to be early onset osteoarthritis. And being in the States, very enthusiastic orthopedic surgeons undertook double sequential hip replacements in 2009 and 2011, respectively. But importantly, he recovered from these procedures well, and at this point there was no suspicion that he had any underlying cardiac condition. Before he could make it to outpatients, he had 2 further admissions with recurrent pericardial effusions, both times requiring drainage because they were thought to be hemodynamically significant. The difference here, though, was that despite drainage to dryness, there was limited improvement of his symptoms. And in fact, throughout or between his admissions, he had progressive heart failure symptoms of breathlessness, fatigue, and now also peripheral edema. So at this point, he was referred then to his tertiary heart failure centre, which is in London, for investigation of what was diagnosed at this point as recurrent myopericarditis. He was seen as an outpatient, and they ran him through the cardiac MRI scanner. And this had shown a slight worsening now of his left ventricular function. He now had an ejection fraction which was measured at 34%. Tissue characterization of his myocardium showed no active edema, but late gadolinium enhancement, which was in keeping with circumferential fibrosis, and quite a significant amount of this. There was no pericardial thickening that would lead to an obvious cause for his effusions, and the diagnosis at this point was a dilated cardiomyopathy of uncertain etiology. He was also submitted for an endomyocardial biopsy, but this returned an equivocal result. There was no active inflammation, some scant fibrosis on the samples that were obtained. So again, here we're left with no unifying diagnosis, likely a dilated cardiomyopathy. It is important to say that at this point he was fairly symptomatic of his heart failure. He was in NYHA class 3. He was started on the appropriate heart failure medication in the way of a beta blocker, a mineralocorticoid receptor antagonist, and sacubitril valsartan or Entresto. This predates the guidance for SGLT2 inhibitors in heart failure. But despite being on fairly optimal, or was felt to be optimal heart failure medication, he was admitted a couple of times with decompensated heart failure, this time more heart failure rather than effusion, which was the cause of his admissions. One admission severe enough that he required a protracted ICU stay with inotropic support. His symptoms improved slowly while in hospital, and he was stepped down to the ward. But given his recurrent admissions, he was referred this time as an inpatient for further review in his tertiary heart failure centre. They undertook a raft of tests, which I'd like to share with you now. An ECG, which is on screen, is remarkable for the fact that he's in atrial fibrillation, but that the QRS complexes are very small throughout the limb leads. This was thought to be representative of his pericardial effusions. The cardiac MRI, which is on screen, showed now worsening of his ejection fraction, now measured at 20%, and there's also mention of a suspicion of an apical thrombus reflective of his poor left ventricular function. You see here a fairly bright white pericardial effusion, which is persistent. But I'll draw your eye here to this white late gadolinium enhancement, which is throughout the myocardium in the septa here, and also in the free walls. And this represents the fibrosis here in this case. And it's seen throughout his myocardium, and it had advanced from his previous imaging. He also went on to have a repeat myocardial biopsy, which again was equivocal. And paired left and right heart catheters, which showed raised intracardiac filling pressures, but no diastolic equalization of his waveforms. So this wasn't a constrictive pericarditis. He had a variety of tests to look for autoimmune causes of this condition. They were fairly nondescript. He had an ANA titer, which was weakly positive, an ANCA, which was weakly positive in a perinuclear pattern, but importantly, his PR3, his MPO antibodies were negative. The remainder of his autoantibody screen was also negative. Given he had a DCM, he also had a gene panel taken for 121 different genes implicated in diabetic cardiomyopathy, all of which returned negative. And there was no significant family history to point to a heritable cause. So again, people were a bit stuck here in terms of the diagnosis. He was commenced on steroids given his recurrent effusions, but people weren't really quite sure. And importantly, his syndrome of heart failure was worsening quite significantly. Appropriately at this point, he was referred now to Royal Papworth Hospital for consideration of transplantation. Papworth is one of 6 cardiac transplant centres in the UK and covers a fairly large patch for referrals, and we take some patients from London centres. There's a lot of head scratching among the MDT at this point, because the consensus from the MDT, which was not taken lightly, was that although it was unclear what the cause of this gentleman's heart failure was likely to be systemic, given the mild changes in his autoantibodies. And whatever it was persistent. And so whatever is affecting his native heart was thought likely to affect his transplanted heart with early recurrence and therefore failure of his allograft. So at this point, the MDT had decided that given the likelihood of failure of a new transplant, he was unlikely to be a candidate for heart transplantation. So at this point, he was referred back to his local team, and absolutely hats off to them, because they spent a long time scratching their heads and talking amongst themselves and trying to work out what was a unifying diagnosis for this gentleman. Given the suspicion of a systemic cause, he was discussed and referred to the rheumatologist, who undertook a very broad screen, again for inflammatory and autoimmune processes, all of which was negative. Chronic infective processes, again negative. He underwent DPD scanning for amyloid and a PET scan for sarcoid, and again, these were normal. And they even screened him for hemochromatosis and underwent a heavy metal screen. And this is where the penny dropped, because his cobalt levels were absolutely through the roof. He had a serum cobalt of over 5,000, where the normal range is less than 118. And they went back to look at his tissue biopsy, and the tissue cobalt level was about 2,000 times the level expected of cobalt in the myocardium. And so this now is thought likely to be representative of a cobalt cardiomyopathy. It's a very unusual cause of dilated cardiomyopathy. I'd like to take the opportunity just to go through it with you slightly, if that's okay. So cobalt is present in a variety of sources. It's present, people can be exposed to it in their occupation, particularly in heavy metal processing plants and diamond polishing, interestingly. It used to be used as a supplement, and cobalt is known to stimulate red blood cell production and was previously used as a treatment for anemia. No longer. It's used in a variety of industries as a food additive. But what's important here is that it's also leached from medical devices. Small amounts of cobalt are leached from, for example, dental implants, but the main culprits here are typically metal-on-metal joint replacements. And this is what the culprit we think in our gentleman was. The pathophysiology here is that you get a release of nanoparticles from the cobalt. Now, cobalt is important at a low level as a modulator of the cardiovascular system to adapt to stress. But when it's in very high levels, it increases reactive oxygen species and interferes with calcium metabolism. And the net effect of that is that you get a reduction in the cardiac function, and you get interruption of cell structure, you get hypertrophy of the myocardium, eventual apoptosis, and then that's replaced with fibrosis. The natural history of cobalt cardiomyopathy is that you get progressive left ventricular dilatation and diastolic dysfunction, and symptomatic heart failure that comes with this. There's a very thorough review article in 2016 in Circulation looking at cobalt-related cardiomyopathy and how that compares to other non-ischemic dilated cardiomyopathy. And there's a couple of pointers that would point towards this. Importantly, the rapidity of the progression of the severe heart failure, and the fact that if you catch it early enough, you take away the cobalt source, you get a regression of the syndrome. But importantly, they are prone to getting recurrent pericardial effusions, and you get a low voltage across all the ECG leads. And our gentleman ticked a lot of these boxes. The treatment is such, the most important thing is to remove the patient from the source of cobalt, whatever that may be. If you, as I've said previously, if you catch it early enough and you take away the source of cobalt, that LV dilatation improves and the symptoms improve as well. You support them through this with standard heart failure therapy, with diuretics if necessary, and other sort of heart failure modulating medication. There's limited evidence for chelation of the cobalt with a variety of agents, but these are not very frequently reported. But if the exposure to cobalt is chronic, then you get development of fibrosis, as we've described, and that is unlikely to be reversible. And so these patients are potentially either progress severely enough to succumb to the condition, or for consideration of advanced heart failure services, which may include mechanical circulatory support or indeed transplantation. So our patients, in fact, on going through his medical records, turned out that he had in fact had bilateral metal-on-metal hip replacements. And he'd actually gone on to fracture, having fallen onto his left side. He'd gone on to fracture his left hip replacement. And it was that, we believe, which is implicated. It's the scraping and the scraping of one metal surface against the other that causes a release of the nanoparticles that is likely to cause his rapid progression of his symptoms. The plan, therefore, as we discussed, is to remove him from the source of cobalt. It was discussed with the orthopedic surgeons in London who undertook bilateral hip replacements of his hip replacements, revisions of his hip. And he had those taken out in June and November of last year. And it's important at this point that the source of his cobalt toxicity is now presumed to be removed. Critically, I'll emphasize at this point that the bulk of hip replacements are not metal-on-metal hip replacements. They are typically metal-on-ceramic. There was a vogue for these because they were felt to be more durable. And a lot of these went into patients in the mid and late 2000s, but they're now not the predominant hip replacement that you'll find in your patients. So having taken his hips out, he was then referred back to Papworth Hospital, brought in for formal transplant assessment. There were concerns here about the severity of his heart failure. So he had by now had multiple admissions with decompensation. He was starting to be intolerant of his heart failure medication. So his Entresto dose had to be reduced because of hypotension. And objective markers of the severity of heart failure were poor. So he had a cardiac index of less than 2. He had a peak VO2 on exercising of 42% predicted, and his NT-proBNP was elevated at 2,600. And all of these were markers of severity of his heart failure and likelihood to do poorly with respect to his heart failure. Importantly, his cobalt levels were rechecked, and these were found to be suppressed. And the feeling now by the MDT was that he had left ventricular systolic dysfunction, which was unlikely to improve despite near normal cobalt levels, given the significance of his fibrosis on his MRI scan, and that he was likely to benefit from heart transplantation. So indeed, he was listed for this and underwent DBD transplant from the routine waiting list in April of this year. He did remarkably well. He had a good post-operative recovery on the intensive care unit, fairly uneventful post-transplant progress, as you'd imagine, post-heart transplant, and was discharged home within 2 to 3 weeks following satisfactory levels of his immunosuppression. His explant was sent for histology, and I'll go through this briefly. It showed ventricular walls showing variable myocyte hypertrophy with some myocyte loss. But what was unusual here was the diffuse interstitial and perimyocytic fibrosis, and no significant inflammation, which is important because it says that the source of his cobalt was likely to be low at this point. So the cardiac pathologist issued a diagnosis of DCM, dialytic cardiomyopathy, which was unusual, and this is in keeping with the diagnosis of his cobalt cardiomyopathy. The patient continues to do well. He's under regular surveillance at this transplant clinic. His cobalt levels importantly remain suppressed, and to date has good function of his allografts, and we keep him under surveillance and see how he gets on. So the take-home message here, I think, is very important to seek out, ideally, the cause of the heart failure, because that has implications on how that is managed. A detailed history really is the key, and this can't be emphasized enough. But nonetheless, if you're up against the brick walls, phone a friend, because someone may have seen this before, and as always, to refer early, both to the frontline heart failure services, but also to advanced heart failure services where appropriate. And I'd be keen to hear if anyone had come up with a connection with Mo's Tavern and this case. But actually, this came to light in the mid-60s when there was a raft of cardiomyopathy among beer drinkers, interestingly, in North America, and it was found at the time that was when cobalt was used as a foam stabilizer for beer. And it was thought that about 20 to 25% of the of beer sold then had actually very high levels of cobalt in it, and the reports there had shown quite a massive influx of patients who responded very rapidly once they were told to stop drinking beer and when the cobalt was taken out of beer as a fortification. So I'll stop there. I'd like to thank very much the team at Papworth for helping putting this case together. I'd be very happy to answer any questions you might have.
Thank you, Paul. This was great. May I start with the first question, actually, and I invite questions to be put into the chat, please. It struck me a bit that the MDT decision initially, when you did not yet know what the diagnosis is, was not to transplant because of the risk of recurrence of a systemic disease. I mean, if you use that yardstick, actually, most transplantations or many transplantations of several other organs actually would not be pursued at all, actually. Is that really the rationale, or was that the rationale?
So I think the difficulty here is that the concern, as you'd imagine, is its use of a very limited resource, which is transplanted organs in patients who are likely to do well. The difficulty, I think, is it was unclear what the source of this gentleman's cardiomyopathy was at that point in time, and I think it's certain. So that I probably portrayed it slightly differently, in that it wasn't necessarily a closed door. It was we can't take this on board at this point in time. It needs a bit more work, I think. And I don't know if Steve, you wanted to chip in at this point and see if were there any different rationale for you from your end.
Sure, Paul. No, I agree with you. I mean, ultimately, we have to believe that there is a good chance of a patient faring well after undergoing heart transplantation. And if we genuinely believe that there is a background pathology that is likely to lead to recurrent disease in the transplanted heart, then that doesn't represent a responsible use of a very scarce resource, a new heart.
Okay. I mean, it's certainly different than in liver disease with regard to recurrence of PSC, or in the old days, essentially a recurrence of hepatitis C, which did not stop essentially transplanting that organ, which is interesting actually to listen. Okay, here are a few questions actually. Chris Powell, is there any information on the cobalt content and manufacturing controls for the hip prosthesis used? Are this type still in use actually?
Yes. So actually, researching this, the bulk of papers not in cardiology journals, but in fact in orthopedic journals. So this is a fairly well recognized complication among orthopedic surgeons, at least the bulk of them. So yes, it is still a used prosthesis. It's very much used in a minimum of cases. And it's thought actually that it's not the actual prosthesis itself which is cobalt generating, but it's when the prosthesis fails that you tend to get the syndrome develop. However, the prostheses were initially brought on the market because they were thought to be more stable. This has turned out not to be the case. So yes, it's a well known risk of using the devices, but the risk generally is felt to be relatively low.
Thank you. And here is a question from Quillen Webb, actually. In the iron cardiomyopathy, we see in hemochromatosis that P2 MRI can be quite striking due to the iron load. It really lights up. Does anything similar happen with cobalt as well?
So no is the answer. This particular case, at least, didn't have particularly different T2 weighted images. I think there was no obvious, and from the journals that I've sort of found, there's no obvious MRI findings that are specific to this cardiomyopathy, which makes diagnosing it fairly tricky in terms of using imaging. I think it's the syndrome together with the history that would sort of push you towards this, and of course serum levels if you're concerned.
Thank you. Here, Dr. Krogano, great presentation. The cobalt was only found on the myocardial biopsies when it was specifically looked for. Is that right?
That's correct, and I don't think so. It wasn't a particular morphology that was the concern. It was actually the cobalt content. And so the sample had to be sent to a reference lab to have it tested for cobalt. It's not something that they do routinely.
I have a question actually related to that. You refer to cobalt nanoparticles. Is it really nanoparticles actually, or is it atomic cobalt that causes the pathology?
So the specific pathophysiology, I think, is I'm not overly familiar with. But my understanding is that it's a combination. You get cobalt, which interferes with calcium homeostasis, and that affects how the myocardium behaves and functions. I think there are some reports of nanoparticles also being infected and deposited, but I suspect it's probably both.
Okay, so a similar phenotype is not observed with other types of nanoparticles that we are constantly being exposed.
I don't know is the short answer, but I know that there are similar pathophysiology with things like arsenic poisoning and selenium poisoning, actually.
Right, which also have essentially direct effects on enzyme activities, etc., which may be a little bit different. Excellent. I think this was all in time. If we don't have any further questions, I would like to close the session. Thank the presenters for terrific cases and terrific contexts, actually. And I'll see you again next week then. Thank you.